Now we move on to session 3. I would like to invite the chairpersons, Dr. V. Malar Selvi. Madam has got 17 years of experience in Tamil Nadu Government Service, 25 years as she is working as OG consultant at Sarda Hospital, New Perugalathu. Her areas of interest are infertility. I would like to call upon Dr. Aval M. Madam is ex-president OXI and IMA Perambur. She has got 33 years of experience at Madras Medical College. She has got an administrative experience of 10 years. We welcome you, ma'am.
In Madurai, all the obstetric things happens because of gynecology.
Good morning, dear friends. Actually, today the focus from fetal echocardiography has switched over to maternal echocardiography. Now, should we do it as a routine or only in selected cases, and what is the importance of it? Heart disease affects approximately 0.2 to 4% of pregnant women, and it's the leading cause of maternal mortality as well as morbidity, both in unfit cases as well as in newly diagnosed heart disease indicating pregnancy. Maternal mortality in pregnant women with heart disease is about 1%, which is about 100 times higher than those without any heart disease. We know right from undergraduate days we have learned the various changes that occur during pregnancy in almost every system in the body, more so in the cardiovascular system, and profound changes in the circulatory system that occurs are like increase in the cardiac output, heart rate, hemodilution, and so many things. And these changes may compromise a limited cardiac reserve. In that case, a heart disease may be manifested for the first time during pregnancy. This may not be seen earlier. Fortunately, most pregnant women with cardiac disease, they have got a favorable fetal and maternal outcome, except some conditions like Eisenmenger, obstructive pulmonary vascular disease, and so on, in whom the maternal and fetal outcomes are not that good. But even these other cardiac diseases, even though it is not so severe to cause mortality and morbidity, still they are at risk for other complications like heart failure, arrhythmia, and stroke. Therefore, echocardiogram is the gold standard and definitive diagnostic tool for diagnosing heart disease. Now, you have to remember that pregnancy is a cardiometabolic stress test. It can unmask previously undiagnosed cardiac conditions or precipitate de novo disease. Now, while pregnancy is recognized as a time of hemodynamic stress for women with underlying cardiovascular disease, it is now recognized that a substantial portion of pregnancy-associated cardiovascular complications are due to acquired complications, risk factors like obesity, pre-existing diabetes, pre-existing hypertension, and so on. Now, in response to the altered loading conditions of pregnancy, the normal heart undergoes reversible remodeling that may take weeks or months to revert back to normal in postpartum. Now, these pregnancy-induced cardiovascular changes can stress maternal physiology sufficiently to adversely affect women with pre-existing heart disease. That's very, very important. Now, beyond pregnancy, the postpartum period is one of the elevated risk as far out as a year postpartum, with approximately 1/3 of maternal deaths occur during this postpartum period. So, sonographers as well as clinicians should understand the normal echocardiographic findings in pregnancy and also recognize the abnormal changes that may precipitate prompt clinical review. Now, substantial overlap exists between the symptoms that commonly accompany normal pregnancy and those that signal early manifestation of cardiovascular disease, including hyperventilation, anemia, weight gain, and edema. But as such, echo is a clinically invaluable tool for the evaluation of pregnant women, both in the context of underlying, that is pre-existing heart disease, and also those without known pre-existing heart disease, presenting with symptoms that are challenging to distinguish from an uncomplicated pregnancy. Furthermore, it is widely available, echo is widely available and it does not require the use of any radiation or intravenous contrast. Now, as you know, there are various symptoms that occur in pregnancy like fatigue, dyspnea, decreased cardiac exercise capacity, peripheral edema, heart murmurs, and so on, which may mimic a cardiac problem also. And some symptoms like orthopnea may not be there in normal pregnancy, which may be present in cardiac failure. So, you should be in a position to differentiate the symptoms whether it is a normal pregnancy or in a impending cardiac failure. So, though the symptoms and signs of cardiac recompensation are similar to the symptoms and clinical condition for normal pregnancy, when there is a breathlessness out of proportion to gestation, orthopnea, paroxysmal nocturnal dyspnea, resting sinus tachycardia of more than 100 beats per minute, clinical signs of heart failure, all these things are going to warrant prompt cardiology assessment. Of course, in addition, N-terminal prohormone brain natriuretic peptide levels are just slightly raised in pregnancy, more so in preeclampsia and very high in heart disease. But of course, this we cannot do as a routine, so we prefer to do a echocardiography. Now, when we talk about echo in pregnancy, we should have 5 important points. Now, normal echo findings, both structural and functional. What are the changes in the echo? And echocardiography findings in pregnancy-induced heart disease, like pericardial cardiomyopathy, pulmonary embolism, aortic dissection, hypertensive disorder, pregnancy, and so on. And what are the echocardiography findings in women with pre-existing heart disease, like valvular disease, cardiomyopathy, pulmonary hypertension, and so on. And also, you should know echocardiography trials and surveillance during and after pregnancy, and practical advice on screening the pregnant women. Because of increased cardiac output, dilatation of all chambers occurs, but they are within normal limit, which revert back by 3 to 6 months after delivery. And there is also a 5 to 10% overall increase in the left ventricular mass and bone thickness of 25 to 30% above pre-pregnancy levels, but all staying within normal limits. There is also some asymptomatic small pericardial effusion of no hemodynamic consequence, which occur approximately 40% of pregnancies. There are more, these changes are more common in third trimester, especially when the weight is more than 12 kg. Now, all these changes typically resolve by 6 weeks postpartum and they don't need any further review. But not much of a significant change in the functional thing of echo findings, in pregnancy. There is no significant change in left ventricular ejection fraction. Maybe there is a subtle decline to low normal, which is observed in second trimester, which persists into the early postpartum period also. Now, therefore, is there a need to do an echo in mothers? As such, when there is a pre-existing structural disease, definitely there is an important role in assessing the severity of the disease by doing an echocardiogram. All of us agree. Now, those who develop cardiovascular symptom during pregnancy, again, echo is a key imaging tool for assessment of the hemodynamic and structural changes, which is recommended by ACOG as well as FDA. However, routine screening intervals, when we should do this during pregnancy for various cardiac conditions, they are not well defined. That results in a clinical heterogeneity in care. Now, echo is the imaging modality of choice for defining, risk stratifying and monitoring the cardiovascular changes throughout pregnancy. Once we identify that at-risk patients, of course, they should receive careful individual counseling as well as follow-up. Now, again, normal pregnancy, the echocardiography, these things you should remember. The ejection fraction shortening, and average systolic pressure, all these things remain unchanged in pregnancy. There is an increase like LV mass, cardiac output, LA size, volume, and all those things during pregnancy, and pericardiac effusion and pseudodyskinesis are normative in pregnancy. So, what is normal echo finding in pregnancy also you should know. A large proportion of cardiovascular events occur de novo during pregnancy in women without known pre-existing. This is area we should remember. Without known pre-existing CVD, and echo should therefore be utilized as a first-line imaging modality of choice. All the more when they show any signs and symptoms of cardiovascular disease. And obviously, echo is quite safe in pregnancy. That is the main advantage of this. But only thing is that supine positioning can be challenging due to compression of the IVC, and left lateral deficit positioning is therefore preferred one. And of course, contrast study is not advised. Some advise agitated saline contrast, and again exercise stress is same, no pharmacological stress. And women with obesity, and all these high-risk women with obesity, diabetes, and they are at high risk for abnormal echocardiogram, and they also have the high risk for preeclampsia. Now, screening echo can help identify obese women at the highest risk of severe preeclampsia. Okay. Now, a word about the echo in preeclamptic women. It's quite interesting to find this, that in preeclamptic women, maternal echo studies have demonstrated significant cardiac dysfunction even before the preeclampsia manifests. This is the point you have to note. Now, the cardiac output was significantly lower in early onset preeclampsia compared with late preeclampsia, as demonstrated by Galaxy et al. A recent systematic review in 36 studies covering about 815 women with preeclampsia demonstrated that increased vascular resistance and left ventricular mass were the most consistent findings with preeclampsia. Now, LV was thickness of more than 1 centimeter, exaggerated reduction in early diastole, atrial contraction, and all these things are markers of diastolic dysfunction which are seen in preeclampsia, and these are other findings which differentiate from a normal pregnancy. Diastolic dysfunction and left ventricular remodeling are most marked in severe and early onset preeclampsia, and that is associated with poor maternal and fetal outcomes, irrespective of the conventional classification of preeclampsia based on clinical severity or gestation onset. Now, so far, earlier we were classifying preeclampsia as a mild, moderate, severe. All these classifications are to decide what is going to be the prognosis for the mother as well as baby. Then subsequently, now we are changing it over to early onset and late onset. Now, in future, we are going to classify tests according to the cardiovascular manifestation and echo changes, cardiovascular risk. Now, what are the changes in echo in gestational hypertension and preeclampsia? It is a valuable tool in stratifying risk and can guide the management in preeclampsia. Now, changes in the cardiac function and morphology are recognizable at an asymptomatic early stage and correlate with the disease severity and adverse outcomes. Now, what are the things that we see in preeclampsia? High risk women in whom recognizable cardiovascular changes occur even before manifesting clinically as hypertensive disorder. So, even before the preeclampsia hypertension occur, we can find out the cardiovascular changes by echo. And already established gestational hypertension or preeclampsia, you can even classify them as who are at severe risk or at lesser risk from their echocardiac findings. Okay. Now, this is how you do that. Now, the upper one is the standard care which we normally do, whereas the lower one is the echo-assisted care in preeclampsia. If you do an echo in the mid-transit, that is 21 to 33 weeks, you can classify it as low risk when the wall thickness is less than 1 centimeter, normal systolic function, and the lateral ejection is more than 14 centimeter per second. Whereas, if the wall thickness is more than 1 centimeter, LV ejection fraction is less than 50% and the lateral is less than 14 centimeter per second, they are at high risk. This is how you classify based on the echocardiography finding in this hypertension patients. Okay. Now, if they are at high risk, you have to give an intensive management. Not standard care is not enough. You go for a increased frequency of BP, proteinuria monitoring, appropriate medical therapy, timing the delivery, echo-assisted fluid, but all these areas you have to concentrate according to the risk, according to the echocardiography finding. Now, the echo changes in cardiac structure and function can be detected even before the clinical condition preeclampsia appears. Now, current evidence suggests that alterations in the preeclampsia are not because of the hypertension or loss. We all know it is a multi-organ disorder. So, changes occur in the cardiovascular system, in the hypertension and all those things. So, the changes in the cardiovascular system are prevalent even before preeclampsia appears. So, that we can make use of and picking out those patients are likely to go for preeclampsia. Now, preeclampsia has a greater impact on the heart than gestational hypertension. And echo has the potential to improve the management of patients with hypertension during pregnancy and categorize the patient, as I told you earlier, into either a high or low risk group. Patients with increased vascular resistance and left ventricular mass are more likely to have complications. Now, many times we see that preeclampsia patients, we cannot predict which level of hypertension they will go for all complications, maternal or fetal. Even with almost a near normal or a low high BP, still they will go for complications. So we cannot predict in whom. Whereas using this echo, we can predict who are likely to go for a complication. As a predictor of long-term cardiovascular morbidity, diastolic dysfunction in pregnancy is important to identify and also reduce fraction may be useful as a predictor of preeclampsia. And it can also, echocardiography can also identify a small number of women with LV with systolic impairment who are more likely to deteriorate during pregnancy and postpartum. Now, it is also useful in the management of preeclampsia. It is suggested that echo can stratify hypertensive pregnant women into hemodynamic subgroups, thereby enabling clinicians to tailor the choice of antihypertensive therapy, in whom to give beta blockers, in whom to give calcium channel blockers, and all. Hypertension characterized by vasoconstriction, they respond better to beta blockers, whereas hypertension with reduced plasma volume, they respond very well to calcium channel blockers because they reduce afterload of the cardiac function. And echo can also have an important role in guiding the fluid balance, which is one of the most challenging aspects in the management of preeclampsia. You know, overzealous fluid administration can lead on to pulmonary edema, and conversely, if a patient is underfilled, again end-organ dysfunction. So this is very, very important. And in selected centers on patients, myocardial strain imaging has also been shown to be more sensitive than LV ejection fraction in detecting the difference in the LV systolic function in women with and without preeclampsia. So, echocardiography is also central to counseling women with a history of PTCM with respect to the risk of subsequent pregnancy. 47% of aortic dissections occur in pregnant women who were not previously aware of an aortic at all until after the dissection occurs. So, these patients can be detected earlier. In women presenting with chest pain in the absence of clear-cut acute coronary syndrome, then TEE remains a readily accessible and safe diagnostic tool to assess the LV function, regional wall motion abnormalities, and non-ischemic findings which may contribute to the symptoms. Now we are very clear that echo has to be done in a pre-existing disease to assess the severity, right? All of you agree. Now echo has to be done in women with symptoms. Then also provides you have to differentiate between the normal pregnancy symptoms and the cardiovascular symptoms. Now, without any symptom, just like that, in every pregnant woman, are we justified screening with echocardiography? Now we want evidence. Now there is a study recently in Tantra Medical College where they have done a study in around 300 pregnant women. They found that, as all of us know that in India, rheumatic heart disease outnumbers the congenital heart disease. So identifying the heart disease in asymptomatic pregnant women it becomes necessary. And echo is the gold standard to definitely diagnostic tool to diagnose the heart disease. And in 2019, 300 pregnant women without any previous heart disease and they are asymptomatic, they were taken up for screening echocardiography. And they found that there were about, of course, in all trimesters, first, second, third trimester, they were taken, they found 6.3% of patients had either a congenital or acquired heart disease. Among these acquired heart disease, burden is about 63% and congenital heart disease about 37%. And among the rheumatic etiology, isolated stenotic lesion was 50% and regurgitation was 33% and combined was 16.6%. So they concluded that the baseline evaluation of cardiac function and heart disease before conception can provide an opportunity for the relevant counseling. But of course, if it is failed, at least during pregnancy, if you do that, you can identify the disease and manage them accordingly, provided you can prevent all sorts of complications. Physiological changes that occur during pregnancy may precipitate decompensation in those with a previously well tolerant. That is why they were not diagnosed earlier. The care of pregnant patients with heart disease requires special attention to diagnosis, treatment as well as for follow-up. And conducting systematic, accurate and realistic risk assessment for potential maternal and fetal complications and anticipated adverse outcomes both during pregnancy and postpartum is very, very vital for the success and safety of pregnancy. Now this study has shown that screening echo will definitely be helpful in identifying heart disease and reduce the maternal mortality related to heart disease. So this will justify routine cardiac assessment even in the absence of any symptoms. But of course, at present there are no larger studies or clear-cut guidance in India for universal echo screening in mothers. Now there is another study in California about whether is there any need for routine screening. Now pregnancy-related CVD can be classified as women with pre-existing heart disease and pregnancy-induced heart disease or not without any symptoms. And they have found that there are, in those patients also there are 3.1% deaths due to cardiovascular disease with they had a pre-existing diagnosis, whereas most diagnoses are only made postpartum. 48.4% of the deaths due to cardiovascular disease were made only postpartum. Additionally, 64.1% of patients who died from pregnancy-related CVD, they had an underlying medical condition also. So these are all the findings at various studies. So they have found that most women who die from CVD during pregnancy or postpartum do not have a prior diagnosis of CVD or cardiomyopathy. And California study have developed algorithms to screen all pregnant women as well as postpartum to allow stratification into either a low or high risk group. Now, it's not yet the standard care for obstetric providers to incorporate a robust screening for management and strategy for the antenatal care of the patient. Due to these, that is additionally differentiating the normal pregnancy symptoms and CVD symptoms is again a bit difficult. It's a challenge to the providers. Because of this existing gaps in healthcare, provided misdiagnosis leads to delay in drug treatment as well as of course 26% of maternal CVD related deaths and 37% of cardiomyopathy deaths and 62% of pre-eclampsia related deaths. Now these things can be avoided provided you do the antenatal echo screening and diagnose them earlier. So ACOG has given the guideline that better you go for a universal CVD screening for all women in antepartum period. And again, early recognition of CVD will help triage women at risk to initiate appropriate timely treatment to prevent maternal mortality and morbidity. And most important is a new diagnosis of CVD during pregnancy, like peripartum cardiomyopathy. All these things definitely help. Identification of the risk factors. Again, like hypertension or obesity, diabetes at all, identify them along with the universal CBD screening, definitely assist early diagnosis and reduce the maternal mortality. Another Turkey study in 900 women has also shown that 5.2% of CBD has been detected in healthy pregnant women in the first trimester without any symptom. That means that such a number of cardiovascular disease in pregnancy may be missed if you have not done an echocardiogram. Just 2 more slides. Now, incidental septum, secondum 18 centimeter ASD has been diagnosed. It is 1.9 to 1.5 centimeter seen in a pregnant woman who decompensated during delivery. This is an incidental finding. So many women with ASD may remain asymptomatic, and during pregnancy, increases in cardiac output and blood volume are counterbalanced by a decrease in the pulmonary vascular resistance with a resultant decrease in the left to right stenting. So echo is very useful in determining the defect size, right atrial enlargement, right ventricle volume overload, and quantification of shunt size. Another study in Dernland that has shown that women with high risk, class 3 obesity, 40% of the women and comorbid condition, they were found to have an abnormal screening echocardiogram. This study demonstrates the potential role of echo to identify women at increased risk of worsening hypertension and pregnancy-related cardiac complications. So, dear friends, to conclude, women with pre-existing cardiac disease need pre-pregnancy counseling. That time itself, we have to make a diagnosis of cardiac disease even before they are pregnant, and pre-pregnancy counseling should include the cardiac evaluation also. And pregnancy being a cardiometabolic stress test, it can unmask the underlying cardiac disease. And detecting the cardiac disease early in the antenatal period can definitely go a long way in reduction of maternal mortality. So screening not only in high-risk women but also universally becomes mandatory. Echo is the imaging modality of choice because it is very, very safe. And once the defect is identified, at least patient should receive careful and individual counseling and follow-up. Special reference to gestational hypertension, as I told you earlier, you can identify it even before it manifests, and also risk classification and management, and cardio obstetric team care is an evolving new strategy which we have to take care of. And before I conclude, take this. Number one, when I consulted and I had a discussion with Dr. Justin Paul, cardiologist of the registry, he is under the impression that clinical evaluation of cardiovascular system is good enough. No need for an echo. But when I discussed with our obstetricians, they said there are 2 points. Clinical examination is a bit difficult technically. Second thing is that we are not competent enough to make a confirmed diagnosis by clinical examination alone, so we prefer to have an echo. And third thing is that I discussed with the HOD of Madurai GRS, Medical College, and she said that because in NHM they are making routine mandatory for echo for all antenatal patients at least once in the second trimester, and they have found lot of rheumatic heart disease and few of congenital heart disease also, and definitely it helps a lot in identify the cardiovascular disease in the antenatal period itself and manage them efficiently. So we need further more studies to confirm and make a clear-cut guideline that echo has to be done as a mandatory one universally for all pregnant women. Thank you very much.
Thank you, madam. So if Tamil Nadu has become mandatory for all the aging and they make it usually echo is a compulsory. Yeah, they were
not become guidelines have not started. It may be soon will get a guideline.
Correction. One thing which I think is that our new understanding about preeclampsia, because that is a suboptimal cardiovascular performance, which is the placenta is not willing but it is a victim, and then again it like endorses the thing that we must be careful, especially in changing obstetrical demography. So this is something to think ahead. A lot of brainstorming among us, and a brilliant presentation.
Actually, when I gone through these references and all only, I learned this relationship between the echo and the preeclampsia. That's really quite interesting and very useful. Very useful, yes.
Any more questions? Thank you.
And another thing is that many times fearing the in-laws, they hide that they are having a heart disease at all, and that also can be brought out. Not to bring complaint against the daughter-in-law to the mother-in-law, but at least to save the patient. So that again happens in many cases. Thank you very much.
Next, I invite
Dr. Manisha Adai Beck, Professor at Aval Department of Fetal Medicine Unit, Christian Medical College, Vellore. She is trained in fetal medicine, Wellington Regional Center for Fetal Medicine in New Zealand between 2012 and 2015. She is the president of Vellore Obstetric and Gynecology Society between 21 and 23. She is a member of National Committee on Genetics and Fetal Medicine between 2022 and 2024. She is a peer reviewer of PMC Pregnancy and Childbirth, International Journal of Gynecology and Obstetrics, and Journal of Obstetric and Gynecology. She is talking today on USG shockers in the trimester.
A very good morning to everybody. Thank you, Dr. Chakravarti, Dr. Umaya, and the Cox team for giving me this opportunity to talk on ultrasound shockers in the third trimester. So, I'll be discussing under various contents. I'll try to make it as clinical as possible so that it is relevant. So, when we do the third trimester ultrasound, what is it usually indicated for? So, we assess the fetal growth. So, we look at the biometric measurements that Dr. Chinmay was talking about in the morning. We also look at the amniotic fluid or the liquor around the baby, and we look at the placenta, where the placenta is located, especially if we are suspecting placenta previa. Now, sometimes what happens is when we are doing an ultrasound in the third trimester, we do tend to pick up anomalies even after a normal morphology scan, and that is around 0.2 to 0.4%. Now, what are the type of anomalies that one could come across in a third trimester scan? So, there are many anomalies. Once those which were missed during the 18 to 20 week routine scan, there are certain anomalies which develop over a period of time, especially the kidney anomalies, the renal pelvis dilatation. There are some which were acquired during pregnancy because of infection or because of hemorrhage or things like that. The pickup rate again depends upon what is the approach we are using. If we are using a targeted approach to pick for anomalies, we will find anomalies. If we are just using an opportunistic approach, just doing a scan and see, just get away with the growth scan, then we will probably not pick up anomalies which we would have picked up. Then again, it depends upon the type of system, the baby's system which is involved. If it is a kidney or the genitourinary tract, you are more likely to pick up an anomaly in comparison to a cardiovascular system, most of which are usually picked up by the second trimester. Again, presence of multiple anomalies. Usually these are picked up much earlier. If you have a single anomaly, these are picked up later. So this was a study which was done by Drucker et al. It is a systematic meta-analysis which was published in the British Journal of Obs and Gynae. And they looked at 13 studies, and almost like 1,41,000 women were studied. All of these had a normal second trimester morphology scan. And then when they did a third trimester scan, they found out that 3.68 out of 1,000 women did have anomalies. And most of the common anomalies that were picked up was genitourinary, followed by CNS and CVS. So genitourinary, again the most common thing that we find is the renal pelvis dilatation, which we must remember that if it is getting picked up later, almost 1/3 of it is physiological and it is transient and usually disappears after the baby is born. Then again you have gonadal cyst, mostly ovarian cysts, duplex kidneys, multicystic kidney disease, and posterior urethral valve, unilateral renal agenesis, and sometimes hematocolpos. Very rare, but we do pick up. CNS anomalies, by far the most common that we pick up is ventriculomegaly, that is the dilatation of the lateral ventricle. Or you have a baby with a small head, or what is known as microcephaly. This is exclusively a third trimester diagnosis because you need to follow up the growth of the biparietal diameter or the fetal head over a period of time. Then we look at corpus callosal anomalies and various other anomalies. CVS, most commonly what is picked up is your ventricular septal defect. Arch abnormalities like coarctation of aorta, which can progress over a period of time, are also picked up in the third trimester. So coming to our case 1, so I've put together 10 cases so that we can just discuss about these cases and see how it helped with the diagnosis during the third trimester or it did not help with diagnosis during the third trimester. So our first lady, she was a second gravida, previous one abortion, married for 9 years. This was a non-consanguineous marriage. She had a combined first trimester screening. She did not have a combined first trimester screening. Outside morphology scan was told to be normal at 20 weeks, and she came to us at 28 weeks. So at 28 weeks, what we found was that the K1 septum pellucidum was missing, and you had the lateral ventricle which appeared like a teardrop shape, or what is known as colpocephaly. So the diagnosis that was made was complete agenesis of corpus callosum. So what is the incidence of this anomaly? 4 per 1000 live births. Usually what is a corpus callosum? It is nothing but it's a large bundle of fibers which connects the two halves of the cerebrum, the left and the right cerebral cortex. So it can go missing because of a lot of problems. Either there is a chromosomal problem or an aneuploidy, or there is a genetic syndrome, or if there is an intrauterine infection or any teratogens like cocaine, alcohol, all these have been implicated in this absence. So what we need to do, again another thing to remember is it is also associated with a very high incidence of intracranial and extracranial anomalies. So we need to rule out other anomalies in the brain, especially in the cerebral cortex. We need to also rule out extracranial anomalies. And if these are present, poor prognosis. So these are the ultrasound findings which I already explained. If it is an isolated finding, then usually the outcome is neurodevelopmental delay is around 30%. But to rule out other anomalies and genetic syndromes, it's a very difficult, it's a challenging task to say that it is truly isolated. So then, in that case, the counseling becomes quite challenging. Recurrence risk, if it is an isolated finding, around 3 to 5%. If it is associated with a genetic syndrome, the recurrence risk depends on that. Coming to our case 2, this was a primary mother, no antenatal risk factors. Antenatal checkups were done elsewhere. We did not have morphoscan details, but she was verbally told everything was normal. She didn't have the images. At 37 plus 1 week, she presented to us, and this is what we found. So this is a transverse axial view of the fetal head with a cyst, with a anechoic cyst in the center, and you can see that the cyst is taking up a lot of color. So it gave us an information about vein of Gallen malformation. So what is a vein of Gallen malformation? It's a very rare anomaly. So it was followed, so because she presented at 37 weeks, we followed up the baby very closely because these babies are likely to develop fetal anemia, hydrox. And finally at 40 weeks, she had a normal vaginal delivery, and at birth, the shunt size increased, which normally increases baby had high output cardiac failure, which required treatment. And finally, the arterial filiation, some of them would like these babies to deliver normally. Majority of them, it is important to remember that they are born with heart failure, so a very quick stabilization of these babies and embolization as soon as possible is required. Again, depends upon how the babies are. If they are very bad, then even with embolization, they may have a bad outcome. There can be a mortality at the time, or they can even have a neurodevelopmental delay even if they survive the procedure. So coming to our case 3, she was a 29-year-old, gravida 3, para 1, living 1 with 1 abortion, married for 9 years, non-consanguineous marriage. First was a normal vaginal delivery, girl baby 2.9, baby is alive and well, no issues. Second pregnancy was a spontaneous miscarriage at 3 months. ANCs in Bangalore had a morphology scan at 20 weeks, which was told to be normal. She came to us at 31 plus 1 weeks for routine antenatal checkup, and this is what we found on scan. So if you can see here, what we found is, again, this is the transverse axial view of the fetal head. You can see that there is unilateral dilatation of this dilatation of the lateral ventricle on one side. So there is unilateral ventriculomegaly. And in the lower image, you can see that the lateral ventricle linings are quite echogenic, and there is something like a echogenic debris, which was a blood clot sitting inside the baby's brain. So a diagnosis of intracranial hemorrhage was made in this case. So then we wanted to confirm the diagnosis. Fetal MRI showed intracranial hemorrhage. All the other structures, corpus callosum, everything was well developed. Sulcation, fissuration were appropriate for the gestational age. So one of the common things that could cause this is what is known as fetal neonatal alloimmune thrombocytopenia. So that is what we need to rule out. Basically, there is a mismatch between mothers and fathers' platelet antigens. So the mother's platelet, if the baby is having father's platelets antigen, the mother creates antibodies which will destroy the platelets. It's very similar to what we see in the rhesus isoimmunization. Only instead of destroying the fetal red blood cells, the mother is destroying the fetal thrombocytes or the platelets. And because the platelets falls, the baby develops intracranial hemorrhage. So prognosis again depends upon what is the degree of hemorrhage. In our case, it was a grade 2, so 50% chance of a good outcome, meaning normal outcome, or mild neurological impairment. If it is grade 3 or more, it is severe outcomes. So this is a quick word about fetal neonatal alloimmune thrombocytopenia. It's important to know that 10 to 30% of these babies can present with intracranial hemorrhage in utero. So this is a diagnosis that we should keep in mind when we see these babies. Again, as I told, prognosis depends upon the degree of bleed that the baby has had. Now coming to case 4, third gravida, 2 living issues, no problems, 35 plus 3 weeks, previous to normal vaginal delivery. Both babies were alive and well. Antenatal checkups elsewhere came for delivery. Morphology scan was normal. And then this is what we found on scan. So here we can see there is a well-defined homogeneous hyperechoic mass arising from the walls of the cardiac ventricle. And this is what is a rhabdomyoma, and you can also see that there is some degree of pericardial effusion. We assess the flow to see whether there is any outflow tract obstruction because of that, but the flow to the valves, the flow across both the outflow tracts was quite good. So this baby was diagnosed with a cardiac rhabdomyoma. Baby, she went into spontaneous labor, 38 plus 4 weeks. Baby boy, 3.2 kg. Postnatal echo findings were confirmed. Now, baby is being followed under cardiologists, and they are planning on a resection. But cardiac MRI is also being planned because there was some doubt whether this could be some other tumor like a pericardial teratoma or something else. But mostly on ultrasound finding, it did look like a cardiac rhabdomyoma. So the important thing to remember about rhabdomyomas, 75 to 80% of them are associated with a genetic condition called tuberous sclerosis. So if you find a cardiac rhabdomyoma on scans, you should actively look for tuberous sclerosis, ask for family history of seizures or developmental delay. All these could point out towards tuberous sclerosis. And genetic testing should be done because it is an autosomal dominant condition, so 50% chance of recurrence in each pregnancy. And in tuberous sclerosis, you would also find rhabdomyomas in the baby's brain, in the what are known as cortical tubers. In our case, we did not come across, we had just the heart showing the rhabdomyoma. Now coming to case 5, she was a 23-year-old, married for 2 years. Antenatal checkups were elsewhere, morphoscan again was normal. Risk factors, she was gestational diabetes who was on diet, sugars were well controlled on diet, a known case of hypothyroidism on naproxen, and at 30 plus 3 weeks she had a scan which showed fetal bradycardia, so she was referred here. So this is what we found on scan, fetal bradycardia, fetal heart rate was going on at 80 to 90 beats per minute. There was pericardial effusion to the extent that we could see the heart was structurally normal. So when we saw fetal bradycardia, we made a diagnosis of congenital heart block. Congenital heart block can be associated with a lot of conditions, but one autoimmune reasons are important to rule out. So we did an anti-SSA, anti-SSB antibody status of the mother, and these came back as surprisingly very high. And anti-nuclear antibodies were negative, which was 2 plus, APLA was negative. So a diagnosis of primary Sjogren syndrome was made in the mother just by picking up congenital heart block in the baby. So this baby, 30 plus 3, we kept on following the baby on serial scans to see whether the heart rate is worsening, whether the baby is developing any heart failure or any other issues because of this congenital heart block. And finally, baby delivered at 38 plus 4 weeks by epidural SCS. So this is what is about congenital heart block. I am not going to go into. When we diagnose this, is it important to know it is a multidisciplinary management, and the couple should be sent to cardiologist at some point of time to make them aware that this will require a pacemaker installed in the baby at some point of time, depending upon how bad the heart block is at the time of delivery. So serial scans to do. Usually mother does not require treatment once the heart block is set in, but if the heart block is very, very severe and the baby's heart rate is going below 50, then we generally tend to give some beta sympathomimetics like salbutamol to the mother. Coming to case number 6, G2P1L1, 34 plus 3, no antenatal risk factors, previous child alive and well, morphoscan reports not available. 34 plus 3 weeks came with anhydramnios, and this is what we found. So the kidneys were bilaterally hyperechoic, enlarged, appeared solid. The diagnosis of polycystic kidney disease was made. Another thing to note was there was no lighter in around the baby, so there was anhydramnios. So this is what was the diagnosis that we made. Overall guarded prognosis because of chances of severe pulmonary hypoglycemia. Spontaneous labor at 38 plus 4 weeks, delivered a baby boy, 3.4 kg, baby was depressed at birth. Kidneys were grossly enlarged, palpable. Chest X-ray showed bilateral, severely hypoplastic lungs, and baby died on day 2 of life. So polycystic, yes, just finishing. So polycystic kidney disease, again genetic origin. When you find this on the scans, we must do the evaluation because risk of recurrence is there. So case 7, again priming gravida, no risk factors. Everything was all right till 35 weeks when the abdomen showed an intra-abdominal cyst, and a diagnosis of a gonadal cyst was made. Gonadal cyst can be quite benign, but in this baby it was not so. So when the baby was born, 2.8 kg, it was a girl baby, and finally when the baby was taken up for a laparotomy, it had actually clotted. So the baby needed to undergo left oophorectomy, and the histopath of the cyst came back as serous cystadenoma. So again, gonadal cysts are some things that are exclusively diagnosed in the 3rd trimester. Mean gestational age and diagnosis is 33 weeks. If they are very large, more than 4 to 5 centimeter, then risk of torsion is very high, so we need to observe. But mostly they will resolve if they are small in size. Coming to case 8, I think I'll skip the case 8. Yeah. So this is a pregnancy which is, okay, I think I'll stop here. This is one last case that I just kept. 3rd gravida, para 1, living 1, A1, 34 plus 3. She was an obese woman with a BMI of 35, gestational diabetes or oral hypoglycemics, ANCs in Tirupati told to be normal. Presented at 34 weeks, this is what we see. Gross ventriculomegaly involving both lateral ventricles, and the spine had, the neural tube had not closed, so the spinal column was actually exposed to the amniotic cavity. Again, so we see this is what is known as long segment myelostenosis. Basically, the spine is exposed to the amniotic fluid and it has not closed. It's a severe form of neural tube defect which is fatal. Unfortunately for this lady, it was not picked up. And why it was not picked up? In meningomyelocele, you will see a sac, so people will usually not miss it. But in this case, there was no sac, so probably whoever did the scan missed it. So in this case, the baby succumbed soon after birth. So the take-home message is additional 9.1 to 25% of structural anomalies can be picked up on 3rd trimester ultrasound. Anomalies that are likely to be picked up are those that are evolving or tend to present late or were missed at the anatomy scan. Minimum standard examination should be of the brain, heart, GIT and kidneys. At least these 4 should be seen even when we are doing a 3rd trimester scan. Sometimes it may improve neonatal outcomes, but most of the times it is not able to. Thank you so much for your attention.
Cases. The counterpart Dr. Revati Sadasivam, she is a MD, DPNB and MRCOG candidate. She did a thing in UK, many years, and she had special interest. She is very much interested in reproductive IVF, infertility and endocrinology, reproductive technology and embryology. She did an embryology training at UK and she finished her MRCOG in 2016. So the younger editions she has finished all the things. Over to you. She talked about the elevator thickness and USG, IET.
Thank you, ma'am. Thank you for those kind words of introduction. At the outset, I would like to thank COGS organizers for giving me an opportunity to participate in this grand academic show. I carry warm regards from Erode. Today my topic for presentation is Endometrial Assessment in USG, incorporating the AITA consensus. Basically speaking, ultrasound evaluation of endometrium is something that we do on a day-to-day basis. There is nothing new for me to add upon it. But my topic for today is incorporating the AITA consensus into our clinical practice and what kind of impact it has on the clinical outcome. So this is the overview of my presentation over the next few minutes. We will basically talk about what is AITA consensus, what are the components included in it, what is the purpose of incorporating it into our clinical practice, what are the kind of images it has to include, the kind of clinical significance, and also the limitations of this consensus. Now, AITA is basically the International Endometrial Tumor Analysis Group formed in Chicago in 2008. They came up with certain recommendations, mainly to standardize the terminology that we use on ultrasound reporting of an endometrial lesion. So they also came up with certain recommendations to upgrade the diagnostic accuracy of an endometrial pathology. They came up with certain scoring systems so that we can reliably distinguish between a benign and a malignant endometrial lesion. So what is the purpose of incorporating it into our practice? We know the basic fundamentals of CA endometrium. This is the 6th commonest malignancy in women, and it accounts for almost 30 to 50% of malignancies of the female reproductive tract. And early identification of CA endometrium is something which can give a very good prognosis because the 5-year survival rate is more than 90%. This is a point worth to be noted because early identification in this malignancy is going to give a very good prognosis to the patient. So that's the reason why we do have to increase the diagnostic accuracy of the endometrial lesions. So whenever we are dealing a case with postmenopausal bleeding, actually less than 10% of cases with postmenopausal bleeding will have an identifiable malignant intrauterine pathology. But the point to be noted is that 90 to 95% of cases with CA endometrium will have an episode of significant postmenopausal bleeding. So we need to customize the diagnostic evaluation and we cannot generalize one evaluation for all. Commonly what we do on our OPD basis is that we do either a diagnostic hysteroscopy to do a biopsy or we do dilatation and curettage. Both are quite invasive and they do not assess the depth of involvement or the invasion. Then we do have the alternative technique, which is an MRI. It is quite expensive modality of screening, but it can reliably suggest us the depth of invasion. So finally, we have honed down to TVS, which is a cost-effective modality and the availability is also good enough. We do not generally consider tumor markers into this because they are neither sensitive nor specific for a case of CA endometrium. Relatively potent biomarker for CA endometrium is HER2 biomarker. So these are all the components included in this AITA consensus. We need to evaluate the endometrial thickness, the endometrial echogenicity. We need to look into the endometrial midline appearance, the regularity of the endomyometrial junction, the presence or the absence of the intracavitary fluid. We need to look into the bright X sign. Finally, we include the Doppler scores. We look into the color score as well as the pattern of the vessels. This is an image which shows that how an endometrial evaluation has to be done. The uterus in the sagittal section, a complete sweep from the right to the left end, and the uterine corpus should cover at least 75% of your screen so that your measurements are quite precise. This shows how clinically significant it is. These are all the various components. We look into the endometrial thickness, and in a premenopausal women, if the thickness is more than 20 mm, it is quite significant. Similarly, in a postmenopausal women, if the thickness is more than 15.1 mm, it is quite significant. But the point to be noted is that in postmenopausal women with a thickness of more than 5 mm, we start at evaluating. This gives different scoring system where we find this because endometrial thickness of more than 20 mm gives a score of 3. And similarly, when we look into the echogenicity, it's either a uniform endometrium with a homogeneous echogenicity, or it's a non-uniform endometrium which includes heterogeneous echogenicity as well as homogeneous endometrium with cysts. we have to look into the endometrial midline appearance, the endomyometrial junction, the color score, and the vascular pattern. When you look into the color score, it's very well put up across the screen that abundant vascularity is a pathognomic feature for CA endometrium. This is the only variable which is scored maximum points. It has a score of 4. If there is minimal vascularity, it picks up, it gains a score of 2, and if there is moderate vascularity, it gains a score of 3. And similarly, when we look into the vascular pattern, benign lesions usually have a single vessel with or without branching, whereas a malignant lesion with multiple vessels and multifocal origin is also quite significant and pathognomic for a case of CA endometrium. Now let's look into the details of each of these variables. I've just covered up only those factors which are deciding making variables. When we consider the available variables, now echogenicity is the parameter which has the highest reliability. It doesn't have much of intra and inter-observer variability. All cases of CA endometrium will have a heterogeneously echogenic endometrium. But all cases of heterogeneously echogenic endometrium do not amount to malignant pathology. So that's the thing that we have to bear it at the back of our mind while we are trying to interpret a lesion. Similarly, we can see the first diagram shows a homogeneously echogenic endometrium can be either hypoechogenic, isoechogenic, or it can be even hyperechoic. So all these things with a triple line appearance, it usually comes under homogeneous category, and hyperechogenic endometrium is this one which shows irregular cysts. Similarly, we look into the endometrial midline appearance where we expect a linear and a regular midline appearance for a benign lesion, whereas it's interrupted or not so well defined in cases of CA. And the presence of intracavitary fluid, we look into the level of echogenicity. If it's low level echogenic, we are fine with that, but if it has a ground glass appearance or if it has mixed echogenic, it's more towards a malignant pathology. Now, assessing the endomyometrial junction has got a lot of difference between an expert and a non-expert user. So out of the available variables, this is the one which has got the least sensitivity, mainly because of the reporting differences. But usually in a benign lesion, the endomyometrial junction is well preserved, whereas in a malignant lesion or even in cases of hyperplasia, the endomyometrial junction is either interrupted or it's not so well defined. Now this is the bright edge sign. This is usually formed by the echo between the focal endometrial lesion and the surface of an endometrium. The presence of bright edge sign usually signifies the presence of a polyp. And this is also pointing towards a benign lesion. Finally, we get into the color score. The practical or the technical point that we have to remember while we are trying to assess the vascularity in an endometrium is the technical setting. Now the pulse repetition frequency has to be somewhere between 0.3 to 0.6, and you have to fix your wall filter between 30 to 50. Only then you will be able to assess the endometrial vascularity. If it's going to have minimal vascularity, it gains a score of 2 and it is more likely a benign lesion. But if it has abundant vascularity, then it gains a score of around 4 and it's more likely towards a malignancy. Now let's look into the vascular pattern. Most of the times what we see with a benign lesion is a single vessel with or without branching. But if we find multiple vessels as shown in the diagram with multifocal origin, that is also a pathognomic feature for a CA case. Now, scattered vascular pattern you usually find in a case of endometrial hyperplasia, and if we are dealing with a case of some mucous myoma, we usually identify the circular pattern of vessels. Now let's look into the individual endometrial lesions. If it's going to be a case of endometrial polyp, we find a single vessel with or without branching. The endomyometrial junction is usually well preserved, and most of the time we do identify the bright edge sign. Similarly, in case of an endometrial hyperplasia, we find a heterogeneously echogenic endometrium with irregular cyst. The endomyometrial junction is interrupted and we find a scattered pattern of vascularity. Now this is a classic case of CA endometrium. We just have to look into the endometrium. It's heterogeneously echogenic. The thickness of endometrium is also quite high. We find the endomyometrial junction to be completely obliterated. It's not so well defined. The endometrial midline is not separately made out in this image. And when we move into the vascularity part, we find abundant vascularity, and the vascular pattern is multiple vessels of multifocal origin. So this is a frank case of CA endometrium. Now, if we wish to have an enhanced evaluation of the endometrial cavity, we can either do a saline installation or a gel installation sonography. We call it sonohystrography. It gives us a better assessment of the intracavitary lesion. Based on that, if the base of the lesion covers just 25% of the endometrial surface, we call it focal, but if it extends beyond that, we call it an extended endometrial lesion. Similarly, these are the other images that we do encounter with the saline installation histograph. The other thing to be noted is that with fluid installation into the cavity, sometimes you find the contour of the endometrial lining. If it's going to be smooth and undulating, it's usually a benign lesion. But if you're going to have a spiky appearance, then most likely, or a cauliflower pattern, it's most likely a malignant pathology. So these are the limitations of this consensus. Anything doesn't go away without limitation, so we need to consider this as well. There are few variables which has more than 2 outcomes. For example, endomyometrial junction evaluation, endometrial midline appearance, intracavitary fluid echogenicity appearance. So these variables which has more than 2 outcomes has got a lot of difference in between the expert and the non-expert users. And of course, there are few missed cases, especially endometrial hyperplasia and early stage carcinoma cases where the thickness has not gone so high and when it has not picked up so much of vascularity. There are few trials by Cole et al. Who strongly suggest the addition of Doppler into the grading and differentiation between a benign and a malignant lesion, but still there are few studies which do not support this concept. They do not include the vascularity part or the color score into their differentiation point. So we do not have an absolute numerical cutoff to say that below this number it's going to be a benign lesion and beyond this number it's going to be a malignant pathology. It's quite arbitrary. So these are my simple take-home points. Low-risk endometrial lesions are those with lessened endometrial thickness of less than 5 mm, where they have a homogeneously echogenic endometrium, or where the endomyometrial junction is quite regular and they have little or no vascularity. And or sometimes we do have, as in the case of polyp, a single vessel with or without branching. And then high-risk lesions are those where the endometrial thickness is more than 12 mm. Heterogeneously echogenic endometrium is very, very sensitive, and interrupted or not so well-defined endomyometrial junction is also a significant factor if well analyzed. Similarly, abundant vascularity score and especially the vascular pattern of multiple vessels of multifocal origin are very, very sensitive and specific as well. Now we have Kavi et al. He has run the maximum number of trials on this ITA consensus, and he has shown that 100% of CA endometrial cases, they had non-uniform and heterogeneously echogenic endometrium. And Domini et al. Has given a score of more than 6.5, is more towards the malignant lesions. But this is not a fixed cutoff because the sensitivity of malignancy goes high as and when the score hikes up from 6.5. We have few trials which claims it to be 9. So this we have to interpret it with caution. Thank you all for your patient listening.